multiple myeloma. Multiple myeloma is it's a white blood cell cancer that involves mature lymphocytic lymphocyte white blood cells or plasma cells. What happens is that they secrete a lot of cytokines or antibodies. The plasma cells do, and there are fewer normal cells that are produced when this happens. Fewer RBCs, fewer WBCs, fewer platelets, so they very much have an impaired immunity. It also produces an excess cytokine proteins, which are proteins produced by the WBCs that help regulate part of the cell growth, but it increases the cancer cell growth rates, and it destroys bones in this cancer, in myeloma. And it functions in a way that it can clog up blood vessels in the kidneys from the proteins from that, and other organs with these antibodies and serum proteins. Also, immunoglobulins are overproduced with these antibodies caused by these cancer cells. But it does progressively destroy the bone marrow. Progressively destroys the bone marrow. It affects the kidneys. It creates plasma cells. It can clog up those renal tubules. It can cause bleeding problems. It can cause kidney failure, immunosuppression, and it can lead to death if it's left untreated. The cause is unknown. Again, they suspect that there's a relation between radiation exposure, some environmental and chemical exposures, and infection caused by the human herpes virus 8. They have found that to be an indicator of myeloma. There's no cure, although nowadays the treatment, the progressive treatment for these patients, they tend to live longer than they did years ago, even 20 years ago. So they are advancing in the technology on how to treat these patients. They can develop this over 40 years. Under 40 years, it's rare. You find it more in men than in women, and in African Americans more than whites. The patient usually notices fatigue and easy bruising and bone pain, and even more bone fractures, and easily bone fractures that it doesn't take a lot to fracture their bones. They will have hypertension because of those clogged kidney tubules. Also, they will see higher incidences of infections, let's see, the current, like I said, the current therapies, they lessen the occurrence and the severity of any adverse events. And new studies are saying that there's people that's getting remissions for periods of time, but like I said, there's no cure. It usually will get symptomatic again, and they will have to go through the treatments all over again. So it's very progressive. CRAB is a synonym or a acronym, for what we need to look for in these patients. C standing for, you will see an elevation of calcium. You will see renal involvement from those proteins and cytokines that clog up the renal tubules. You'll see anemia because the RBCs are not as mature, they're not being produced, and we will see a lot of bone lesions as well with these patients. So the manifestations, again, would be the fatigue and the weakness. Now, I might say that sometimes there can be very asymptomatic at the time of diagnosis for these patients. And they usually don't even present until the myeloma is pretty much progressed into the disease process. But you will see manifestations of fatigue and weakness, anemia, bone pain, and osteoporosis are things that you'll know that they'll be complaining of. Spinal compression and fractures, and when that happens, we tend to throw some steroids and things like that at them. Even some surgeries for spinal type surgeries. You will see them have more fractures, easily fractures that just stress fractures and things like that. Renal dysfunction and infections and pneumonia, you'll see that. Of course, like I said, the elevated calcemia and or hyperviscosity of the blood, just from all the proteins and cytokines in that blood. Central nervous system changes as well, such as confusion, vertigo, hearing loss, paresthesia, ataxia, things like that. Even can progress all the way up to seizures and somnolence and stupors and comas. Now, plasmapheresis has been known to remove some of these proteins, can be done on some patients. So for diagnostics, we're going to be looking at the labs. The labs have pancytopenia. You will have decreased RBCs, WBCs, platelets. You will see that hypercalcemia. You'll also see some proteins in the blood. You'll see the pathological fractures on radiology and skulls, even skull lesions. You'll pick up on the osteoporosis and even spinal compression. So the patient will be complaining many times of back pain, weakness, even paralysis in their legs and numbness in their lower extremities and stuff. They may even have some upper extremity involvement there as well. And then you'll see an increased amount of plasma cells in their bone marrow when they do a bone marrow aspiration, for sure. So for treatment, it may be a watchful waiting. For minimal disease, that's what they would prefer to do until they start showing symptoms. There's no cure for it. So until they know that the symptoms are going to deteriorate the patient, then, like I said, if it's just minimal disease, they may watch until that happens. Chemotherapy, the choice depends on the patient's performance status, on their age, their renal function, the patient's, since it's such an ongoing disease, it might be the patient's desire for whether they want inpatient or outpatient therapy. Could be appropriate to have autologous stem cell transplant that can help some patients with this. So many things are on the horizon to try to see what they can do for this disease. Ambulation. It's good that they ambulate. I mean, it's going to cause them to be able to decrease that calcium in their blood. It uses that calcium. But we also don't want them to be doing anything strenuous or too much weight bearing. So that is very, you're going to have to explain that and show them exactly what they can do as far as weight bearing. Hydration. With hydration, you want to flush out that chemo if they get the chemo, probably up to 3 to 4 liters a day if you can get that in them. It dilutes that calcium. It prevents further renal damage, and so you want to try to maintain an output of at least above 3 liters a day. That's preferable for these patients. And then, of course, pain control, because these patients usually get a lot of peripheral neuropathy, not only from the chemo drugs they have, but from other things to do with the compressions in their back. But So NSAIDs can be very effective for them, such as ibuprofen, Motrins, different things like that. And braces can also support them too, as far as pain control. Um, so we want to treat a lot with radiation. So they'll do those kinds of therapies. They'll target the areas of the pain, such as any kind of bone pain or things like that. They'll target those. Um, they'll be giving some steroid therapy as well. That they can get that in high doses to decrease the swelling and that spinal cord compression. They also, like I said, get some surgeries like a lumbar laminectomy or kyphoplasty, which they inject cement into a compressed vertebrae, and that helps there too. You'll also get some radiation to these areas as well. Plasmapheresis for the renal failure. And of course, again, we're going to try to maintain optimum hydration for these patients. They may have to have extended hemodialysis, and that can happen in at least 25% of the patients can, with neuropathy, will have this dialysis. Oh, excuse me, let me go back. They may have extended dialysis, and they can get neuropathy, especially after the dialysis, depending on how much came off from dialysis. They also can get chemo, and for these patients as well. Okay, then we're going. That leads us into hemochromatosis, and that's the end of the myelomas.